Morning. My name is Dr. Stephen Little. I am the Cardiovascular Fellowship Program Director at Houston Methodist Hospital. And this morning is my distinct pleasure to introduce to you two really special guest speakers for today's Grand Rounds. This is a tradition we started about 3 years ago where we invite our graduating core cardiology fellows to present Grand Rounds before they graduate. And they're always very excited to have this opportunity. Generally, there's a podium involved and a live audience, but given the special circumstances, they've been very flexible and they've offered to do this remotely, and we're thankful for that. I think I was supposed to remind you that this is a somewhat interactive session. We're going to have two shorter talks, each splitting the 1 hour session. We'll have a little brief QA period in between. On your screen, I think you see the how to submit some text questions, which we'll sort of review and try to get to at the end of each talk. You can text DeBakey to 37607 and use your text message there using the poll software. So I think without further ado, what I'd like to do is introduce you to our first speaker, is Dr. Faheem Beg. He is going to talk to us about CT-FFR. Is it ready for prime time? Faheem, we're excited to hear what you have to say on this topic.
Thank you so much, Dr. Little. It is my honor and great pleasure to be presenting at the Houston Methodist Grand Rounds this morning. The topic of my presentation is CT-FFR, is it ready for prime time? I have no relevant disclosures. The objectives that I aim to achieve by the end of this presentation are as following. We will try to identify the limitations of CT coronary angiogram and hence make a case for CT-FFR. We would then describe the computation of FFR-CT and its role in our current contemporary cardiology practice. We will move on to discuss the diagnostic accuracy of FFR-CT by discussing several trials over the last decade which has compared this particular modality to invasive indices of coronary flow reserve, such as IFR and FFR. At the end, I would like to spend a couple of minutes to identify some of the pitfalls that you should avoid when you're using FFR-CT. So this is a table that I picked from a review article by Dr. Al-Mallah. He lists several indications for a cardiac CT based on our current guidelines. As you can see, several of these indications have workup of coronary arteries as their primary goal. It wouldn't be unfair to say that assessment of coronary arteries is the most common indication for performing a cardiac CT. With our latest scanners, we get some high quality images and we can see a spectrum of disease as you can see in these images. Unfortunately, the cardiac CT is limited in its accuracy. In this particular study from 2005, looking at the diagnostic accuracy of a 64-slice cardiac CT, we found that the sensitivity and the negative predictive value of cardiac CT is really high. However, the positive predictive value is a decimal 66%. In this particular study, only 26% of the patients had a calcium score which was higher than 400. And as you all are aware, as calcium scores go high, the diagnostic accuracy of a cardiac CT falls. Another important thing to remember is cardiac CT only provides anatomical information. And in this day and age, physiology trumps anatomy any day. So therefore, there's a role for cardiac CT in our current practice. Unfortunately, our current US guidelines do not identify a role for FFR-CT in evaluation of chest pain or coronary artery disease. These guidelines are, however, more than 5 years old and may have a significant role for FFR-CT in their next version. NICE, on the other hand, after an independent appraisal, recommended FFR-CT as a safe, accurate, and cost-effective option for evaluation of patients with recent onset stable chest pain who have undergone a CT for workup. It is safe because it does not require administration of any additional medications or additional contrast. Additionally, there is no requirement for additional imaging, hence there is no additional radiation exposure. We will talk about the accuracy of CT by discussing several trials in this presentation. The cost effectiveness, I believe, is another talk in itself and is beyond the scope of this particular presentation. So as we are ordering more and more of these tests, it is very important that we understand how FFR-CT is computed. The first step in the computation of FFR-CT is acquisition of CT images. Then these images are transferred to HeartFlow in California, which is the only commercially available enterprise which computes the FFR-CT. From the CT image dataset, which is transferred in a diacom form, an anatomical 3D model is created. A physiological model is also created from this CT dataset. The creation of physiological model is based on following principles. Myocardial blood flow is directly proportional to the myocardial mass. The total coronary resistance is then calculated by using the flow that we calculated in previous equation. And for pressure, for mean aortic pressure, we substitute mean brachial pressure. Resistance at several points along that coronary tree is then calculated by using a derivation of Murray's law, which states resistance is inversely proportional to diameter. Finally, a simulation is created for maximal hyperemia, in which we assume that the resistance falls to 0.24 of the resting value with administration of adenosine. This computation is then repeated for several thousand points for each patient by supercomputers at HeartFlow. Finally, this physiological information is superimposed on the anatomical tree. This final product is then available to us through an online application. The anatomical tree is color-coded, where red represents abnormal FFR and blue represents normal CT-FFR. In this particular case, we can click the mouse cursor at any point along the anatomical tree and get an FFR-CT value. In this particular case, you can see LAD CT-FFR is severely abnormal, while the FFR-CT in the first obtuse marginal and left main are normal. FFR-CT in the RCA cannot be calculated either because of an artifact or presence of a stent. So we will now discuss several trials which have been published over the last 10 years, and they have evaluated the diagnostic accuracy of FFR-CT against invasive indices of coronary flow. The first of such trials was the Discover Flow trial. This was published in 2011 in JACC. This was an international multi-center prospective trial of 103 patients looking at 159 vessels. As you can see from this table, the diagnostic accuracy of FFR-CT was significantly better than CTA alone. It was at 85% compared to 58.5%. The positive predictive value also saw a significant improvement to 74% from a 46.5% for CTA alone. However, when we look at the lesions with intermediate stenosis, that is those with a diameter reduction of 50 to 69%, the diagnostic accuracy saw a significant dip. The positive predictive value was only 67%, and specificity was also 67% in those with intermediate stenosis. Discover Flow trial was then followed by Defecto trial, which was published the following year in 2012 in JAMA. This was an international multi-center study involving 408 vessels. In this particular trial, we saw a significant reduction in accuracy and positive predictive value, both for all vessels and with vessels with intermediate stenosis. Then came the NXT trial in 2014, where we saw a significant improvement in the overall accuracy of FFR-CT compared to CTA and the previously mentioned two trials. The overall accuracy of FFR-CT was 86% in this particular trial. However, the positive predictive value was still 61%, suggesting that up to 1/3 of patients that we may send for invasive angiography or invasive FFR may be false positives. Then in 2017, Cook and colleagues did a systematic review. This involved 5 studies, 908 vessels from 536 patients. What they found was the diagnostic accuracy of FFRCT was excellent at the 2 extremes. That is, the patients who had completely normal FFRCT or those with very abnormal FFRCT, the diagnostic accuracy of FFRCT was excellent. However, in that intermediate zone, or as some people have called it, the gray zone, where FFRCT ranged from 0.7 to 0.8, the diagnostic accuracy is no better than flip of a coin. We saw the results of Advanced Registry in 2018. So Advanced Registry is an international multi-center registry. They reported results of 5,083 patients in 2018. This study had a unique design in which the CT scan was performed and the results of CT scan were reported back to the referring provider. They were given 3 options for downstream management. These options included revascularization, optimal medical management, or further testing. Once the referring provider had made a decision, they were given the information for FFRCT and were asked to choose the downstream management again. There was a significant reduction in need for additional testing when FFRCT information was provided to the referring providers. What I found interesting in this particular manuscript was there were several vessels which were either completely normal anatomically or had very minimal stenosis, yet had an abnormal FFR. Another important thing to recognize is 67% of patients in this particular registry had abnormal FFR. Despite all these patients had no non-coronary artery disease, they were only at high risk for coronary artery disease. The investigators also reported the actual management of these patients at 90 days. As I have highlighted here, you can notice that even those patients with the most abnormal FFRs, that is less than 0.71, only 54% of them underwent revascularization. We then saw the results of the Pacific trial in 2019. This was a post hoc sub-study of the Pacific trial in which patients who had already undergone CTA were sent for FFRCT performance. So in this particular trial, at a single center, 208 patients underwent coronary CTA, SPECT, and PET. And this was followed by invasive FFR. Once the CT-FFR was calculated for these patients, the diagnostic performance of FFRCT was compared with other non-invasive imaging modalities. What was surprising was FFRCT had the highest AUC, area under the curve, and highest diagnostic accuracy as compared to coronary CT, SPECT, and PET. I would like to point out that the tracer used for PET was not the tracer most commonly used. It was 015. However, when we moved from a primary analysis to an intention to diagnose analysis, there was a significant reduction in area under the curve and diagnostic accuracy of FFRCT. This was because in the primary analysis, only those patients were included who had computation of FFRCT. We can see that there was a rejection of about 50 CTs out of the 208, and FFRCT could not be calculated for these patients. When we included all those patients in an intention to diagnose analysis, we saw the significant reduction in the diagnostic accuracy of FFRCT. The real FFRCT study was the most recent of the several trials which looked at diagnostic accuracy of FFRCT. This was reported in 2019 in Circ Cardiovascular Imaging. This is a single center registry involving 93 patients and 139 vessels. If you look at the scatter plot here, as the FFR towards the upper end of FFRCT, we see a very good correlation between invasive FFR and the non-invasive FFRCT. However, as we move toward the intermediate zone or low values, we see that there's more spread of the data points on the scatter plot. Here's the bar chart which represents the diagnostic accuracy of FFRCT. At the 2 extremes, FFR-CT is near perfect. However, in that intermediate zone, we see a significant reduction in the diagnostic accuracy of FFR-CT. The investigators for this particular study recommended changing the threshold for FFR-CT and made a case by suggesting that the diagnostic accuracy improves when we lower the threshold for FFR-CT as being abnormal. Diagnostic accuracy improved from its 73% to an 83% when we decreased the FFR-CT threshold to 0.70. However, this was at the cost of sensitivity and negative predictive value, hence suggesting that we may miss out several people with actual ischemia if we go for a lower threshold. After seeing all this data, we decided to look at our own institution's data. We looked at patients who had FFR-CTs, and we compared it against an invasive angiogram and qualitative stenosis assessment. All those patients who had undergone an FFR-CT as well as invasive angiogram were eligible for inclusion. Our final analysis included 130 patients with 647 vessels. So this is the scatter plot for our patients. When we tried to compare the correlation between FFR-CT and cath, we found a Pearson correlation coefficient of 0.657. While some may believe that this is a really good correlation, however, if you look at the scatter plot, we see that several of our data points are within those desired quadrants of true negatives and true positives. We still see a few data points within the false negative and false positive quadrant. We found similar results like all the other trials that I have mentioned previously. The diagnostic accuracy of FFR-CT is excellent at the two extremes. However, we see a significant drop in the diagnostic accuracy in the intermediate zone. So was it wrong on our part to compare a physiological test to an anatomical test? To answer that question, we looked at the sub-study of subpopulation where the patients had both FFR-CT and an invasive coronary flow measurement. Almost all of our patients had IFR, and we compared a cutoff of 0.89 for IFR against a cutoff of 0.80 for FFR-CT. We had a total of 21 patients with 26 vessel segments. And as you can see, most of the data points fall within those desired quadrants of true negatives and true positives. We see a few data points in the false positive quadrant, which are borderline measurements, and we see one data point in the false negative quadrant. Again, at the two extremes of FFR-CT, our diagnostic accuracy was perfect, but in the intermediate zone, we saw a significant reduction in the diagnostic accuracy. Next, I would like to spend a couple of minutes to discuss the pitfalls that one should avoid when using FFR-CT. The diagnostic accuracy of FFR-CT is limited by the various artifacts to which CTA is susceptible. High heart rates, motion artifacts, calcifications, beam hardening, all of those are artifacts to which CTA is susceptible, and that's going to limit the accuracy of FFR-CT. The rejection rate in Pacific trial, as I mentioned previously, was about 25%, and that in NXT trial was 13%. So unfortunately, the rejection rate is usually the highest in those who need this FFR-CT modality the most. It is very important for us to get high quality images. For that, we have to use the latest generation CT scanners. We have to make sure that the heart rate is well controlled with beta blockers or whatever medication that's part of protocol at your lab, and optimization of the imaging protocols. The next point that I want to talk about, and I have previously mentioned in the principles that govern the computation of FFR-CT. FFR-CT assumes that everyone has normal microvascular resistance. However, from the PET studies and CFR studies, we know that people respond very differently to maximal hyperemia and adenosine in terms of their CFR. Therefore, in patients who have microvascular resistance, there may be a significant overestimation of the stenosis, of the epicardial stenosis. Finally, FFR-CT at present cannot be performed on vessels with stents or bypass grafts. I would like to conclude my presentation with following points. I believe FFR-CT is a safe option, and it's an important addition to the current tests that we have available for ischemia diagnosis. It provides us both anatomical and physiological evaluation of coronary artery stenosis. It is safe because it does not require administration of any additional medications, contrast, or radiation. The overall diagnostic accuracy, as we have mentioned from our own data and several trials over the last 10 years, is excellent. It has very high negative predictive value and high sensitivity. So if a CT-FFR value is negative, you can be comfortable in saying that the patient does not have ischemia, and also it is very unlikely that you may miss patients with actual ischemia. However, it is that intermediate zone where we see a significant reduction in the FFR-CT. Some people have called this the gray zone, and this can be anywhere from 0.69 to 0.79 or 0.79 to 0.7 to 0.79. That's where the diagnostic accuracy of FFR-CT is significantly diminished. We recommend that in that intermediate zone, you take an individualized approach for each patient. The FFR-CT can be supplemented by additional diagnostic information, such as presence of significant stenosis on CTA or presence of vulnerable plaque, which can be identified on CTA, or taking a good history, and if there's any additional diagnostic tests that are available, all of those should be taken in consideration when making a decision for downstream management for a patient with an intermediate FFR-CT measurement. So I would like to end my presentation by acknowledging the following people. Dr. Al-Mallah, who guided me throughout this last 1 year when I was working on these several projects related to FFR-CT and during making of this presentation. Zafra Salma, who's my wife and has helped me out a lot at every step of my life, and I want to thank the Houston Methodist Cardiology Fellowship leadership for giving us this opportunity to present here today.
Dr. Beg, thank you. That was an elegant review of actually a fairly complicated topic. The principle seems simple, but when you delve into the detail, there's clearly some nuance and really important patient selection issues. We'll pause for a second before we go to the next presentation. Do we have any questions on the POL-V system? And what I'll also ask Faheem, and I'll remind those, if any in the audience would like to pose a question, it's very simple to text it. You text the word DeBakey, D-E-B-A-K-E-Y, and then the number is 37607. Okay, sorry, I'm being asked to, my N95 might have gotten in the way of my microphone. Turn up the volume. It is on. Yes. All right. Okay, there are a couple of questions that have come through. Here's a question for you, Faheem. If CT-FFR works best in extremes, what is then the added advantage of CT-FFR to anatomic coronary stenosis? What's the advantage?
So right now, the way we are using FFR-CT in our lab is we start with CTA. We look for anatomical stenosis severity, and for those with a stenosis severity between 30 and 70%, that's when we would get an FFR-CT. If the CT-FFR is completely normal or completely abnormal, then that gives us the answer. In the intermediate region, that's where we have to take a more nuanced approach to that particular patient. We don't know if the FFR-CT is going to be completely normal or completely abnormal when we send an FFR-CT analysis. So I think it has a role for those who have very abnormal or very normal values. It is in that intermediate lesion where we have to look at the CTA again to make an assessment for ourselves how bad that stenosis was, if there's presence of any vulnerable plaque, and then based on the patient characteristics, we would have to make a decision of how we are going to treat that patient downstream.
So many diagnostic tests perform well at the extremes, and where we often need them clinically to perform best is in the gray zone, and you've clearly raised the concern there. I'll put you on the spot. Can you describe a patient situation where CT-FFR would be helpful?
Again, I think so as we are initially we were doing a lot of CT scans for patients who were low pretest probability, low to pretest probability for coronary artery disease. As we have been doing more and more of these CTs, we are seeing patients with now intermediate to high probability of coronary artery disease and significant ischemia. I think there's probably the role of FFR CT is higher, is probably better in those who have very high probability of coronary artery disease. If we don't find if we find this CT-FFR value which is really high, is completely normal, then I think that is very reassuring.
Okay. I'll maybe ask you one more question, and that should be a quick one here for you. Is, do you know the turnaround time and perhaps the cost, the added cost of performance of this test?
So the turnaround time right now, we are seeing about 6 to 8 hours for from when we send the images to when we get the results back. The cost is, I think it's another talk in itself, but it can be up to 3 to 4 times the reimbursement for the CTA itself. However, there have been several analyses which have shown that downstream it may lead to cost saving by sending lesser patients to the invasive cath lab, which as an interventional cardiologist, future interventional cardiologist, I wouldn't like.
Understood. Faheem, I think you did a great job. I think we'll let you off the hook now.
Thank you so much.
Completed the very last tough thing of your fellowship.
So I get to graduate next month.
I'm going to reserve that evaluation for another month, otherwise I may not see you for the next few weeks. So well done.
Thank
Very
you.
happy with that. We will change gears now and introduce our second esteemed speaker. Dr. Jiken Bhatt is our current chief fellow in our cardiac program. He's going to talk to us today about heart of a Texan and the cardiovascular assessment in the competitive athlete. Over to you, Dr. Bhatt.
Thank you, Dr. Little. It's my pleasure to give a talk on this today, and thank you, Faheem, for a great talk. It's going to be a tough act to follow. So like Dr. Little mentioned, I'm going to be talking about the heart of a Texan. And we're talking about the cardiovascular assessment of the competitive athlete. I have no disclosures, so what are we going to be talking about today? So I'll start off with a little history on athlete's heart and what that means, talk about physiology of exercise and how that relates to athlete's heart, what the structural, functional, and electrophysiologic adaptations are to sport, and finally talk on the screening of the competitive athlete. If we have some time, I'll talk about some legal considerations as well. So the history. So it surprised me to find out that the history of athlete's heart and the term athlete's heart actually is over 100 years old. So actually a Swedish neurologist noted when he examined skiers that their hearts were enlarged after a skiing session. He did this by percussion alone, which is an achievement in of itself. But he also noticed that this was likely a physiologic enlargement and that this was likely beneficial for their sport. Nonetheless, there was a lot of controversy through the 1900s about whether this was truly physiologic or pathologic. So autopsy studies in athletes who died of other causes showed that there was ventricular hypertrophy, but there's no evidence of myocardial damage supporting that physiologic response. In the 1930s, chest radiographs took off, and athletes were again noted to have enlarged cardiac silhouettes when you looked at width, length, and depth of the cardiac silhouette. It wasn't until the 1970s that we got our first echocardiographic images of athletes, and these images were actually published in at the Munich Olympic Games, and they show echocardiograms that are very different than what we're used to, but it showed M-mode images that showed systolic function was actually preserved in athletes, and it augmented with exercise. As M-mode improved through the 1970s, we noticed that different sport athletes had different adaptations, and we'll touch base on that in a little bit. So obviously since that time, we've made tremendous strides in our understanding of athlete's heart, but it's important to understand the mechanism behind these findings. So I want to briefly touch base on the physiology of exercise. So increased oxygen demand is met by increased cardiac output during exercise. As we know, cardiac output is the product of stroke volume and heart rate. So on the figure on the left, you see that stroke volume and heart rate initially increase as you ramp up exercise. As you reach maximal exercise, however, heart rate is the predominant factor in increasing your cardiac output, and that's because stroke volume cannot augment too much. The interesting thing here, though, is that heart rate, maximal heart rate in particular, is actually determined primarily by age and gender. This means that LeBron James and I have the same exact maximal heart rate. So how does LeBron maintain or reach that increased cardiac output? Well, it means that he must have a higher stroke volume. And since he has a higher stroke volume, with exercise, he must have a higher stroke volume at rest, which means he must have a higher end diastolic volume at rest. So where does this cardiac output go? Well, most of it goes to the skeletal muscle. There's small increases in the brain and heart, as well as the skin, to dissipate the extra heat. And there's actually a decreased flow to the abdominal organs due to splanchnic vasoconstriction. So when we talk about exercise, it's important to separate the two into isotonic and isometric exercises. So isotonic exercises are those that we typically consider endurance or cardiovascular training. So this is running, for example. And this results in sustained increases in cardiac output, with actually a drop in the systemic vascular resistance. This means that increased flow has to go through all 4 chambers of the heart and ultimately results in 4-chamber dilation. On the other extreme, we have isometric exercises. This is weightlifting or resistance training. This leads to brief but dramatic increases in afterload and systolic blood pressure. This results in increased pressure seen only by the left ventricle, and this ultimately leads to left ventricular hypertrophy without dilation. So the ACC-AHA created this figure to classify sports, and the reason for that is that sports are no sport is truly all isotonic or all isometric. They classify the dynamic component based on the percentage of maximal VO2 or maximal oxygen uptake from A, B, and C. The static component is graded from 1, 2, and 3 and is related to the maximal voluntary muscle contraction. So for example, running is a 1C sport because it has a high dynamic, low static component, whereas weightlifting is a 3A sport, meaning it has a high static and low dynamic component. At the extremes, we have rowing and decathlons and triathlons, which are 3C sports because these have high dynamic and high static components. And unfortunately for you golfers out there, golfing is a 1A sport. So when we talk about athlete's heart, the first question is, what does that really mean? Well, there is no strict set of criteria. There's no strict definition of what the athlete's heart is, other than there's a set of structural, functional, and electrophysiologic adaptations that all constitute athlete's heart. And this should all be a physiologic response to their training. So how much exercise does it take for these cardiovascular changes? I went on a 1-mile run last week. Does that make me an athlete? Well, this was an older study looking at 127 healthy men between the ages of 18 and 34, and they categorized them based on their weekly hours of sports activity. And you see here, the big cutoff is really at 3 hours of sports activity a week. So beyond 3 hours a week of sports activity, heart rate dropped significantly, peak VO2 increased significantly, and left ventricular mass increased significantly. And this was adjusted for body size. So what are the structural adaptations we can expect in athletes? Well, this was a pretty interesting study. So this is a study out of Dallas that looked at 12 sedentary young adults. And they put them through a pretty rigorous training program. They asked them to basically run a marathon at the end of a year. And they put them through gradual increases in physical activity. The y-axis here is an index for exercise duration and intensity. So you see they started out with brisk walking, slow jogging, 1-hour runs, 2-hour runs, and up until they were training 7 to 9 hours a week. Over the first 6 months, you see the left ventricular mass, wall thickness, and end diastolic volume all increased rather linearly. However, when you look at what happened beyond 6 months, left ventricular mass begins to level off, wall thickness actually starts coming down, and end diastolic volume continues to increase. What this suggests is early in their training, they developed what's called a concentric LVH, meaning the LV mass and the wall thickness were rising linearly with relatively small increases in their volume. As they got beyond 6 months, they actually developed an eccentric physiology, meaning that their left ventricular masses began to level off, their walls began to thin again, and their end diastolic volume continued to enlarge. So this study from 2010 looked at 26 triathletes and 27 non-athletes and just use CMR data to compare their left ventricular and right ventricular volumes and masses. And you see here both ventricular volumes and masses were higher in the triathletes when compared to the controls. What about variation between sports? So this study compared 40 rowers versus 40 runners. Again, rowing is a 3C sport, meaning it's a high dynamic and high static component, and running is a 1C sport, meaning there's a high dynamic and low static component. The study showed that while both groups had larger LV volumes and wall thickness, the runners had normal LV masses. This suggested that the running led to eccentric remodeling, meaning that the LV chamber dilates but the walls do not thicken significantly, and LV mass remains normal. Whereas rowing leads to chamber dilation as well as wall thickening, termed eccentric hypertrophy. So numerous studies like this have been done, and they've been published across across a variety of sports. Essentially, the findings boil down to this figure on the right. So as we touched on when discussing exercise physiology, static exercises such as weightlifting lead to concentric left ventricular hypertrophy, meaning the LV size is normal and there's thickening of the walls with increase in left ventricular mass. Dynamic exercises lead to four-chamber dilation due to sustained increases in cardiac output. This is termed eccentric remodeling. When you have some combination of both, like you do in triathletes and rowers, you get some combination of both of these phenomena, termed eccentric hypertrophy. This becomes important when you're evaluating an athlete. So if a runner comes to you and has concentric LVH, this is not normal for him. Whereas if a weightlifter comes to you and has four-chamber dilation, that should cause you pause as well. There's also significant variations when you talk about gender and race. So comparing male and female athletes, you see female athletes have significantly smaller ventricles, even after exercise, and male athletes have significantly larger volumes. The other caveat is we typically cite 13 millimeters as a wall thickness beyond which you should look for a pathologic hypertrophy. However, when you look at black athletes, a significant portion of them have wall thicknesses beyond 13 millimeters up until 16 millimeters. So again, you should take race and gender into account when you're evaluating these patients. What about functional adaptations? So when we look at systolic function, it's generally believed that systolic function is normal in athletes, and this was shown back in the Munich Games. Although ejection fraction has been shown to be on the lower side of normal, likely due to the increased ventricular volumes. So this study, looking at controls versus cyclists, showed fractional shorting, which is a surrogate for ejection fraction, is normal or is the same between cyclists and controls. Heart rate is significantly lower, and stroke volume is significantly larger, which leads to a generally same cardiac output between controls and cyclists. This study looked at football players after their first season in NCAA football. And again, you see they compared linemen and non-linemen. Ejection fractions were the same between the two groups, and they stayed the same before and after the season. However, when you look a little more closely, and you look at global longitudinal strain, which is a sensitive and reproducible marker for ejection fraction, you see that global longitudinal strain in linemen actually dropped, suggesting that there may be some pathologic process going on in addition to their sport. And this needs to be elucidated a little further in the future. What about diastolic function? Well, here you have an example of a dilated ventricle. You see biventricular dilation and biatrial dilation, all suggestive of an endurance athlete with thickened ventricular walls. When you look at their diastology, unlike a patient with dilated cardiomyopathy, these patients have supranormal filling patterns, suggesting that they have truly physiologic hypertrophy. This study out of the American Society of Echocardiography suggested this algorithm to help differentiate hypertrophic cardiomyopathy from athlete's heart. And essentially they raised the cutoff of septal E prime and lateral E prime from our traditional markers of 7 and 12, 7 and 10 to 10 and 12. And this, they proposed, would increase the sensitivity for hypertrophic cardiomyopathy from 40 to 50% to 65 to 75% in athletes. So what about electrophysiologic adaptations? I'll just touch on this briefly because there is another talk on this in about a month. But the International Olympic Committee consensus statement in 2009 came up with this algorithm. Now this is a little older algorithm, but the basic principle is the same. Certain findings are considered normal in athletes and warrant no further workup. These include sinus bradycardia, first-degree AV block, incomplete right bundle branch block, early repolarization, and isolated QRS voltage criteria for LVH. And then there's a whole slew of criteria that warrant further workup. So this consensus statement in 2017 was generated and endorsed by several societies around the globe. Its goal was to unify the EKG recommendations, which before this had been different across different societies, and to increase the specificity of EKG without hurting the sensitivity. Essentially, they were worried about too much downstream testing with the current models. They made a point to specifically note that age and race play an important role in EKG interpretation. So this is the algorithm that they come up with, a little more nuanced than the one we had seen previously. And specifically, the things to note here is they noticed that ST elevations in V1 through V4 are common in black athletes, up to 60% of black athletes, in fact. And T-wave inversions in V1 through V3 are normal in young juvenile athletes less than 16 years of age. Furthermore, they say complete right bundle branch block in isolation may be completely normal, and none of these require any further evaluation. So just to highlight this point, I want to go through a couple of EKGs. So here you see an EKG of an athlete that shows sinus bradycardia with LVH, ST elevations consistent with early repolarization, and peak T waves. Now, it's easy for us in this talk to say that this is completely normal and no further workup is needed. However, when a pediatrician or a doctor not trained in sports cardiology sees this EKG, it can frequently lead to further downstream testing. What about this EKG? This EKG is clearly abnormal. You see LVH and big T-wave inversions associated with hypertrophic cardiomyopathy, and that's an easy one that most of us would pick up. But it becomes a lot more subtle. So here you see in panel A an EKG of a black athlete with ST elevations and T-wave inversions. This is actually considered completely normal and actually warrants no further evaluation. Again, you'd be hard-pressed if you're seeing a patient and clearing them for sport to not pursue further testing in this patient, especially when you consider panel B. Here again, you see T-wave inversions across the precordium, however, which many would consider more benign looking than the ones with ST elevations in the first panel. However, this is a patient with ARVD, which is a leading cause of sudden cardiac death in athletes. So it's very nuanced to someone who's not trained in this specialty. And that brings us to the screening process for competitive athletes. So the basic questions that I wanted to ask are who, what, when, where, why, and how. So what are the risks for athletes? Well, the risk for sudden cardiac death across the general population in the United States is 1 to 6.4 cases per 100,000 patient years in the United States for those under the age of 35. The vast majority of these occur at rest and are unrelated to sport. What about during competitive sports? Well, the risk goes up. The instantaneous risk is 0.46 to 1.21 cases of sudden cardiac death per 100,000 patient years. This may seem like a smaller number, but remember, this is just at the time of sport, which is maybe 1 or 2 hours during the course of the day or week. And there's approximately 50 to 150 cases of sudden cardiac death in competitive athletes per year. A relatively small number, but remember, we're talking about young, healthy people, and these are tragic events that bring upon a lot of media attention. So why does this happen? Well, there's acute myocardial ischemia, sympathetic surges, and abrupt hemodynamic changes paired with some arrhythmogenic substrate that lead to sudden cardiac death. So the question is, what are these arrhythmogenic substrates? Well, in the United States, in athletes less than 35 years of age, hypertrophic cardiomyopathy is about a third of all sudden cardiac death. Congenital coronary anomalies account for about another 20%, and everything else is less common, including premature coronary disease, myocarditis, channelopathies, and ARVD. Of note, this is only US data. When you look at Italy, 25% of their cases are related to ARVD, and a small minority are hypertrophic cardiomyopathy. Of course, there are certain things you can't screen for, such as blunt chest trauma. So in general, how do we diagnose underlying cardiovascular disease? Well, the majority of cases we get from comprehensive history and physical, usually by a PCP before they come to the cardiologist, through family screening if their family member has a genetic disease, through incidental findings, or through evaluation of symptoms. The question in athletes, though, is would systematic screening help us identify risk beyond those first 4 points? So does screening work? Well, this is a population-based study out of Italy, and it's really interesting because this northern portion of Italy has tracked all of their sudden cardiac deaths since 1979. And specifically, this is the data for those between the ages of 12 and 35. In 1982, Italy implemented a pre-participation screening protocol that was mandated across the country. And you see here, since that implementation, the rate of sudden cardiac death in athletes has dropped precipitously. 2% of athletes in this time period were screened and disqualified from participating. Of note, we are talking about small numbers. This is only 55 screened athletes that suffered from sudden cardiac death over the course of 25 years. And you see here, for unscreened non-athletes, the rate is now the same as for those that are screened athletes. That's not the full story, though. So the Israeli experience has been quite different. They implemented their law in 1998, and that was based on a big spike in sudden cardiac death in the mid-90s. And you see, if you exclude point D here, which the authors claim may have been an anomaly, again, we're talking about small numbers, the trend is about the same before and after the sport law was implemented. And then here in yellow, you see this registry data out of Minnesota, which is our US information. What about a different approach? So Canada actually does not formally screen their competitive athletes. This data was based out of the Rescue Registry, which is a prospective registry of all persons who had out-of-hospital cardiac arrest and were attended to by EMS in Ontario, Canada. And they found, when they sifted through the data, that there were 16 cases of sudden cardiac death in young athletes within 1 hour of competitive sport. Again, the rate that they found was similar to previous data. Of the 16, 7 survived their sudden cardiac death. When they reviewed their echocardiograms and follow-up, only 1 had an abnormal EKG. So they determined that even if they had screened those 7 athletes, they would have only picked up 1 abnormality. Even if, and they claimed that even if screening prevented all sudden cardiac death, they would have had to screen 140,000 athletes to prevent 1 sudden cardiac death. Nonetheless, the US does screen just like Italy and Israel. And the US, Italy, and Israel all screen all competitive athletes. Other countries have taken different approaches, only screening professional or elite athletes, or only screening certain sports. Well, who is a competitive athlete? Well, the AHA and the ACC define this. They define this as any person who participates in an organizer team or individual sport, who requires regular competition, places a high premium on excellence and achievement, and requires some form of systematic or usually intense training. This actually in the United States applies to all middle school, high school, collegiate, and professional athletes, although it is not mandated by law. So the AHA also says how we should screen. They recommend a personal history, a family history, and a physical examination. Note that EKG is not included in this assessment. This is in contrast to Italy and Israel. So the question is, should we add an EKG? Well, we mentioned the Italian study. They used EKGs and they had a large drop in sudden cardiac death rates. The ESC and the International Olympic Committee took this as a sign that they should recommend EKG as part of their evaluation. The University of Virginia did a cost-benefit analysis. So they, over 5 years, mandated EKGs as part of their screening protocol. And they noted that if they had stopped at the end of history and physical, their program would have cost $343,000 to screen 1,473 athletes. When they continued and added the EKG, their cost went up to $894,000. So why such a sharp increase? Well, it was primarily driven by downstream testing. So if they had stopped at history and physical, they would have ordered 23 transthoracic echocardiograms. By adding the EKG in those patients, they ordered another 200 transthoracic echocardiograms. And we talked about the EKGs and why that might be the case. Nonetheless, if you can save lives, this can be justified. So they found 5 cardiac abnormalities with H&P alone, and once they added EKG, they were able to identify 8 additional cardiac abnormalities. They don't specify exactly what these abnormalities are, but it's a little questionable since they only excluded 2 patients from participation out of these 13. So is it really worth screening all athletes with EKGs? Well, in the US, when we talk about all competitive athletes, there's 10 to 12 million athletes in the United States. And so that's quite a tall task. So the AHA, based on this, currently has a 2B recommendation for recommendation for EKGs in small cohorts. They don't define these small cohorts, but they recommend you take into account limitations of EKG and the cost associated. But they have a class 3 recommendation, meaning you should not get EKGs across the board. So suppose you find an abnormality. The question then is, what do you do next? So these set of guidelines were actually released just a couple of weeks ago. And this is the use of multimodality imaging in young competitive athletes. So they acknowledge that imaging is not a first-line test, but if you have any abnormality on your medical history or physical, or you see any pathologic EKG findings, you proceed with a transthoracic echocardiogram. If you definitively exclude by TTE any pathology, you have no additional imaging that is required. However, if there's any pathology suggested, you should proceed with a cardiac MRI, cardiac CT, or stress testing. So I wanted to show just one example of, hopefully this will play for us here, of an echocardiogram of two patients side by side. So this is patient 1 and patient 2. Both are 30-year-old, relatively healthy people. Well, you see dilated ventricles in both cases with preserved or low normal ejection fraction, and you have dilated 4 chambers. When you look a little more closely, however, patient 1 has a completely normal strain pattern, which we again mentioned was a sensitive marker for systolic function, and their diastolic function is completely normal. Their septal E prime is 11.5. Normal is considered 7, or even if you use the stricter criteria, is 10 in athletes. Here you see abnormal strain pattern in patient 2, however, and their septal E prime is at the borderline of normal for non-athletes and is definitely abnormal for a 30-year-old. Turns out patient 1 is a competitive basketball player, and patient 2 is a patient who is recovering from myocarditis. So what is the role of advanced imaging? This is not an imaging talk, but I just want to give a couple of examples. So what can cardiac CT be helpful for? Well, you can see cardiac CT can be immensely helpful for identifying coronary anomalies, which account for up to 20% of sudden cardiac death in young adults. Here you see a case of left main coronary artery arising from the right coronary cusp, traversing between the aorta and pulmonary artery. And this was in an athlete with chest pain and syncope. What about cardiac MRI? Well, cardiac MRI can be extremely helpful in excluding most, if not all, of the major causes of sudden cardiac death, from various cardiomyopathies to abnormal coronary origins. Of course, the issue is when you're talking about 10 million competitive athletes, CMR is a very resource-intensive modality. Finally, since I have a couple minutes, I just want to talk about some legal considerations, since this is an important part of sports cardiology. So this is a case of Knapp versus Northwestern University. So Mr. Knapp was a young high school athlete who played basketball, who received a scholarship to play at Northwestern University. However, before the senior year of his high school career, he suffered from sudden cardiac death and underwent ICD implantation. He was excluded from his senior year of basketball, and when he presented to Northwestern, they excluded him from collegiate sports, but they did grant his scholarship. He sued the university, saying this was a violation of the Rehabilitation Act, which states that any entity receiving federal funds cannot discriminate based on disability. However, the court found that Northwestern's decision to exclude Knapp from his basketball team was legally justified as a team physician used reasonable medical judgment. This case had a little different outcome. So this is the case of Cuttino Mobley. So he was actually drafted by the Houston Rockets in the early 2000s, I believe, or the late 1990s. So he sued the New York Knicks. So it turned out he had a 13-year successful career in the NBA before being traded to the New York Knicks. Upon arriving to the New York Knicks, their history and physical led to a cardiac MRI, which showed that he had hypertrophic cardiomyopathy. They excluded him from playing for the New York Knicks, and he ultimately was forced to retire since no other teams would sign him. He filed a suit saying that he had previously signed liability waivers with his previous teams and should be able to play as long as he provided informed consent. And the court found that he may have a case of valid disability discrimination. Nonetheless, the point for us as cardiologists is to date there's no legal precedent for holding a physician liable for refusing to clear an athlete with a known or probable cardiovascular abnormality. So the important takeaway here is that the threat or concern of litigation should not prevent you from using sound medical judgment in disqualifying athletes from participation. And with that, I take any questions.
All right, thank you, Dr. Bhatt. That was an excellent overview of a very interesting topic and one we don't hear about all that often. Nice timing that there were some guidelines that came out just about a month ago to sort of give you some useful data. Just while if any questions come in the POLV system, I will ask you, so most athletes that we think about are lean, muscular, and when it gets into indexing, which is very important in this group, they're often tall, the BSAs may be large, and you have to index these chambers that you're evaluating. But we don't always have lean athletes. For example, the sumo wrestler. I'm not sure where that would be in the quadrant, but a sumo wrestler who has a lot of intentional extra adipose tissue versus the collegiate wrestler, maybe the same activity. But I'm really trying to get to, what do we know about adipose tissue and indexing and cardiac physiology of fat? Do we count it? Do we not count it? Have you come across anything to guide us in your reading so far?
So I haven't seen too much on indexing specific for athletes, but as we know, we index a lot of our data in the imaging labs, and we usually, for now, index primarily on body surface area. Now, obviously, when you're talking about weight, there's two big categories, as you mentioned. There's a lot of adipose tissue, and then there's lean body weight. And there's been a big push to index more towards height or ideal body weight, because just because someone has more adipose tissue does not necessarily mean that they should have a larger heart or be providing more flow. So in athletes, it may hold true that body surface area is actually a valid measure, and it may not be valid actually in patients who are larger for other reasons.
Okay, thank you. We have a lot of questions that have actually come in on the system. We'll try to get to a few of them in the last few minutes. Dr. Bhatt, what is the role of family history and genetic testing for cardiomyopathies and sudden cardiac death syndromes in the evaluation of athletes?
So, as I didn't come across any specific guidelines specific to athletes, but we do have guidelines for different cardiomyopathies and screening. For example, hypertrophic cardiomyopathy, whether or not there's a genetic component, has different screening algorithms. And when you look at the AHA recommendations, their family history is actually pretty broad. Any kind of premature death in the family, it warrants further testing. And if you look at the algorithms proposed by the MMI algorithms, the next step would be transthoracic echocardiogram as your first test. Of course, if you have a genetic mutation in your family, that should be pursued independent of whether or not that athlete is an athlete or just another family member.
Okay, great. I'm going to take the chair's prerogative here and actually switch over to your colleague and put him back on the hot seat since he's here. And I can see from the Polvi system that a couple of very anxious surgeons keep asking a question actually about CT-FFR. So in the last minute, I'll give Dr. Beg an opportunity. The question, as I recall it coming through, is can you comment about the role of CT-FFR in CABG surgery, perhaps evaluating grafts themselves, and also in the preparation potentially for CABG in the evaluation, for example, of a lima and its appropriateness for use? What do we know about that specific scenario?
So two parts to that question. First one is pre-operative evaluation, I guess, and for second one is the post-operative evaluation. For pre-operative evaluation, I think we got some data from the advanced registry where, as I previously mentioned, the referring providers were given the options of selecting one of the three strategies for downstream management, and revascularization was one of those. Within revascularization, there was option for PCI versus CABG, and more patients were actually reassigned to CABG from a PCI or medical management strategy when FFR-CT information was added. Actually, there was a higher number of people who actually underwent CABG after FFR-CT information was added. So I guess we identified more lesions with ischemia than we could have identified with the CTA alone. That's, I think, the only information that I am aware of for pre-operative evaluation before CABG. For the post-operative evaluation, at present, we cannot evaluate bypass grafts or lima for the with CT-FFR. I believe that is because we have to set the inlet boundaries and the outlet boundaries for the CT-FFR computational fluid dynamics, and we identify the aortic root as the inlet and the distal coronary arteries as the outlet. So that's why we are not able to evaluate anything outside the coronary circulation at present with FFR-CT.
Okay, excellent, thank you. So we are on time. What I will do at this point is I will thank our special guest lecturers today. Thank you both for an outstanding job. You really covered the topics very well. And thank you those that are watching, and we will see you next week.